going to start our joint meeting. This is a joint EECA INTERACT International AIDS Society meeting. The International AIDS Society meeting will continue on to next day. So we have planned a joint program for you this afternoon, and I'd just like to introduce Erik Lundström from the International AIDS Society, who is the mover and shaker behind this idea.
Thank you very much, Kate. The International AIDS Society is very happy to be here in Almaty and also to have this opportunity to collaborate with the EECA INTERACT on this afternoon of scientific sessions. And also, as Kate mentioned, we have another workshop happening tomorrow. And as Professor Kasashkin mentioned before lunch, the IAS Educational Fund is organizing meetings across different regions. And this is the first time that we are actually partnering with an existing meeting in the region here in Eastern Europe and Central Asia. And we've seen that as a great opportunity to also kind of extend the learnings for people. So the way that the Educational Fund works is that we bring the science from our large conferences into the different regions and adapt it into a regional or a local context. So what is very important for our meetings is networking and discussion components. So that means that we will be organizing a dinner tonight, right after the closing session. So we're hoping that as many of you as possible will be able to join us there and see that as an opportunity to continue the discussions that we've had throughout the day.
Okay, so thank you. We will turn over to the first session afternoon chairs, Frank and Anna. Can you take it away, please?
Большое спасибо. Наша сессия посвящена инновациям в странах Восточной Европы, Центральной Азии и вопросу интеграции услуг. И у нас один докладчик, профессор Хавьер Сепеда, Университет Южной Калифорнии.
Спасибо за приглашение и возможность говорить про интеграцию. К сожалению, я не могу сдавать этот доклад на русском языке, но я надеюсь, что эта презентация будет доступна на русском языке после конференции. Okay, so I'm talking a little bit about integration of care for HIV, TB, and hepatitis. And working together towards viral suppression, TB treatment, and HCV cure in the region. Okay, so just to give a little bit of an overview of the presentation, as we've already heard many times already throughout the conference, is that HIV, hepatitis C, TB, and injection drug use are inextricably linked in the region. So I'll talk a little bit about some of that. And also some of the empirical evidence of integration from observational studies that have been done. And also, I'll be presenting some findings from modeling integration, mathematical modeling of integration of treatment and prevention services in the region, as well as talk about some innovative interventions that have been done that I think could be highly applicable to the EECA. And I'll also be talking about some challenges and barriers, and then ending with some conclusions. So as we already heard, these epidemics of HIV, hepatitis C, TB, and injection drug use are inextricably linked, and they interact with each other. And it's actually a term that's often used in literature to describe this phenomenon, and it's called a syndemic. And it was coined by a medical anthropologist. His name is Merrill Singer, and he coined this term actually to describe the HIV/AIDS epidemic in the United States, that he noticed that it was also strongly linked with substance use and violence. And I think it's highly applicable in this region as well. And the definition that he coined was synergistic interaction of two or more coexisting diseases and resultant excess burden of disease. So as we already talked about, people who inject drugs are significantly more likely to be living or at risk of acquiring HIV, hepatitis C, and TB than the general population in the region. There are approximately 3 million people who inject drugs, about a quarter of whom are infected with HIV. Co-infection of viral hepatitis C is highly prevalent, and especially among those that are living with HIV, where it's estimated to be 70 to 90%. People who inject drugs that are also living with HIV have a 2 to 6-fold higher risk of acquiring TB. Actually, a recent study, I believe it was done in Russia, found that the one-year mortality rate was astronomically high. About 27% had died after 1 year. And one thing that we should also discuss is that the death due to drug overdose is also extremely high. It's a competing mortality risk, and that this is primarily attributed to poor access to opioid agonist therapy and naloxone, which is an opioid antagonist. So this is just a schematic showing how all of these, how all this is related, how all these epidemics are related, obviously within the context of injection drug use. But you can see that there are individual and community level drivers, such as poor access to harm reduction, individual stigma, and also community level stigma and discrimination. But then there are also these important structural drivers, such as drug policy, policing, mass incarceration, and also structural level stigma, especially that occurs within a healthcare setting. But there are opportunities for integration because theoretically, integration of evidence-based prevention and treatment programs should synergistically reduce morbidity and mortality at the individual and population level of these co-occurring epidemics. So now I'll talk a little bit about what the evidence shows. So these are data from a systematic review and meta-analysis that was done a few years ago, looking at the impact of opioid agonist therapy on the HIV continuum of care. And so these are all the studies they looked at all the outcomes on the HIV continuum of care. I just selected two. This is just being on ART and also viral suppression. And what they did is they pooled all the estimates here for coverage of ART, and they found that PWID that are on OAT had a 54% increased odds of being on ART compared to PWID not on OAT. And OAT is obviously, this is actually predominantly from methadone because that's where most of the evidence is so far. And then in terms of viral suppression, PWID on OAT had a 45% increased odds of being virally suppressed compared to those who are not on OAT. And these are the pooled estimates. Now, unfortunately, most of these estimates come from high income settings, predominantly in Western Europe or the United States or Canada. But I believe there's just one study here that's from a middle income country, Indonesia. So there's obviously an important need to contribute to this from this region as well. So now I'll talk a little bit about some studies that have been done on integration. One study that was done in Ukraine on integrating HIV and methadone maintenance services. They looked at three different modalities of care. One was an integrated and co-located care where they provided free HIV treatment and testing, TB and methadone. And then they also provided screening for HIV and TB in one integrated center. Then they looked in a non-co-located care where these services were still provided, but in different locations. And then another was through harm reduction and outreach. And they looked at a couple of different outcomes. So in terms of CD4 count, 92% in the integrated care setting had received their CD4 count in the past 6 months, and that was significantly higher than those that were receiving it through harm reduction and outreach. But the real benefit was actually in terms of, actually what I already talked about was on receiving ART, where 50% had been receiving ART in the integrated setting, and it was at least 2 to 2.5 times higher than in the non-co-located care and the harm reduction and outreach center. And then we see also especially high, same kind of trend in those that were receiving ART with a CD4 count less than 200. Now looking at the integration of TB treatment with methadone maintenance, the study was also done in Ukraine. Again, we see similar trends where those that were enrolled in methadone maintenance program had were significantly more likely to be completing treatment after 90 days, or at 90 days. Those that had the mean number of days that they were in treatment was also higher among those on methadone compared to those who were not. I mean, it was still overall quite high, but it's still better among those who are on methadone. And then also the mean percentage of TB medication doses taken was also higher among those that are on methadone. And you can see here, this is the survival curves of those on retention in TB treatment. And the black line, they were quite similar up to about 60 days. And then they diverged at 90 days, where you can see that those who are on methadone were retained longer than those that were not on methadone for TB care. And then probably some of you are in this room were involved in the study. This was a couples-based intervention to reduce HIV, hepatitis C, and overdose in Almaty. And I won't go through all of this, but this was an intervention that was a couples-based intervention. So most of the couples were active or former people who inject drugs. and they had an intervention that focused on HIV, hepatitis C, and overdose prevention, a 5-week session on building the skills and knowledge on how to reduce these risks. And then they had a wellness promotion and also an overdose prevention comparison group. And I didn't show this here, but overdose went down after 12 months in both intervention arms. But there actually wasn't a significant intervention effect on preventing overdose. I think the hypothesis was that the HIV and hepatitis C overdose prevention would be that it would be significantly or be associated with it would have more impact on preventing overdose, but they didn't find that. Okay, so now so that's some of the data on integrated care, interventions that have been done in the region, and now I want to talk a little bit about mathematical modeling of infectious diseases. So the goal of modeling is to develop tools to help public health policymaking. And these can act as test laboratories because they can evaluate the potential impact of intervention scale-up on achieving population-level public health targets and project epidemic trajectories under hypothetical scenarios. So these models are different than statistical models, which the statistical models that I'm sure you're all very well familiar with are describing associations between variables, but there's no mechanism actually provided. So for example, there's a strong relationship between HIV and unprotected sex. But these models that we're talking about are mechanistic models, and they provide a mechanistic relationship between these factors to predict complex system dynamics. So what is mechanistic modeling? It's a simplified representation of a complex phenomenon, and it attempts to, very logically, attempts to mimic the real world. So some uses of this type of modeling is it answers several important questions, but some of them include improving our understanding of the epidemic drivers, such as answering who, what, and where. It also helps disentangle the impact of interventions, such as if you have to choose between different interventions. This is especially relevant if you're doing economic evaluations and you have a fixed amount of resources that you can spend on protected interventions. This modeling will help determine where would you have the most impact under these constrained resources. And also importantly, this type of modeling helps make predictions under different conditions. That can ultimately, as I mentioned before, is to help inform an evidence-based public health response. So this is some work that we did last year for the IAS Lancet Commission on advancing global health and strengthening the HIV response. We did some mathematical modeling of integrating harm reduction with HIV treatment services and in 2 Russian cities. So this was a hypothetical type of modeling exercise where we wanted to see the impact of integrating needle syringe programs and methadone programs in ART in Omsk and in Yekaterinburg, which had 2 different epidemic profiles. So just to give a little bit of background here, each dot represents this was observed in the real world. So this was, for example, in 2009 in Omsk, the HIV prevalence among people who inject drugs was around 9%. And we're basically fitting a model to what we observe. And all these different lines represent different scenarios. Okay, so the gray bar, this is the status quo. So this is what would happen if no interventions, if everything kind of stayed the same. We would expect the HIV prevalence in Omsk to hit about 35% by 2028. But there are different interventions, and we can estimate what would happen under different scenarios. And Yekaterinburg had a different profile where it's been very high and stable for the last 10 years or so at around 60%. And these are the different scenarios, such as scaling up needle syringe exchange programs to 50%, scaling up methadone programs to about 25%, and then scaling up to 50%, and then integrating needle syringe exchange programs and methadone to 50%. And then the final one is needle syringe exchange programs, methadone, and integrating ART scale up as well. And so what we found was that just scale up of harm reduction, such as either needle syringe exchange programs or methadone, to about 50% coverage could avert a median of 35% new infections in Omsk and 20% new infections in Yekaterinburg by 2028. But the integrated scenario, which included the scale up of ART, to about 65% coverage, could avert 53% of new infections in Omsk and 36% of new infections in Yekaterinburg. But there's also an additional benefit of including methadone because there's a strong evidence base on its role in preventing opioid overdose deaths. So what we found was that in the scenarios that had methadone, about 32% of fatal opioid overdoses could be averted in both settings. This was another modeling study that was done they were looking at the impact of integrating harm reduction with ART and then HIV and hepatitis C testing and looking at the impact on incidence among both people who inject drugs and non-people who inject drugs in Belarus, Georgia, Kazakhstan, Moldova, and Tajikistan. So on the left-hand side, this is the impact on people who inject drugs. In the top, it's hepatitis C, and on the bottom is HIV. And then on the right-hand side is for non-people who inject drugs. And you can see, again, kind of similar to what we found, was that the interventions that had the most impact were the ones that integrated harm reduction. So just harm reduction alone would have a tremendous amount of impact on hepatitis C and HIV. And then integrating treatment and testing and providing, well, for hepatitis C, the new direct-acting antivirals, and then an ART, this would be integrating ART. We see an incremental increase in the proportion of new infections that would be averted, and I believe their time frame was over the next 20 years. So now that was some from the modeling. Now I want to talk a little bit about moving forward and opportunities for innovation in integrating services to address HIV, hepatitis C, and TB. So we know at the structural level, the political will might be slow to enact huge changes to the healthcare system or to drug policy reforms. Integration will also involve training a new generation of doctors to treat patients holistically because they'll be coming in with multiple comorbidities. So that also may take time. But the question, and also patients also remain hard to reach. And we also must consider patients that are not living in urban centers as well, where a lot of these resources, a lot of these interventions are found. So what can be done with the existing infrastructure? And I want to talk about two recently published trials that were done, unfortunately not here, but one was done in the United States, and also the other one in the UK, which I'm talking about in just a second. But this was a single-arm trial of using telemedicine to integrate hepatitis C treatment with methadone maintenance. And this schematic shows basically the intervention, what occurred here. So patients would come in, they would have 2 on-site patient educational sessions, and there they would also be tested for hepatitis C. And if they were RNA positive, indicating a chronic infection, they would be further evaluated by a hepatologist and another specialist. Then they'd be enrolled in a telemedicine program where they could have consultations with what they define here as an advanced practitioner. This was biweekly that they would have these telemedicine appointments. And during that time, the hepatitis C medication would be delivered to the methadone program. So in this image, you see the gentleman taking his methadone, and at the same time, he's also having his hep C medications dispensed as well. And this was just a small study, but the adherence rates was actually quite high, that there was a little bit in the initiation of the program, about a little more than 75% had not missed a one dose. But then you can see it got much better as the trial went on, where about 90% had not missed one dose. And this was, each data point that's 2 weeks, 4 weeks, 6 weeks, and 8 weeks. Unfortunately, this study didn't report on the sustained virologic response, but this, like I said, this just came out just a few months ago in clinical infectious diseases. And then the second intervention I want to talk about is on video directly observed therapy for tuberculosis treatment. Although they didn't look at in an integrated setting, this technology could very much be applied for integrating multiple treatment, not just tuberculosis, but it could be coupled with other treatment. But the way that this intervention works is that the patient received a smartphone which had an app already preloaded on it, and the patient will record a video which is then sent in the cloud. It's encrypted, so no one can view it, And only the dot worker, the directly observed therapy worker can view it. They log into a system, they watch the video, and they note it on whether or not the patient actually administered or actually ingested the medication. And so then the dot worker can say, yes, I observed the patient doing this, and they also send SMS reminders to the patient, as well as they keep notes for the provider on if a dose was missed, or just to maintain the adherence. So this was actually, these results were published recently in The Lancet on comparing what they call smartphone-enabled video observed therapy versus directly observed treatment for tuberculosis. And this was done in the UK, but the patients that they were treating were extremely the hardest to hard to reach. These were unstably housed people, a lot of people with substance use disorder or mental health disorders. So these were extremely challenging population, but you can see across, you can see across the board that video directly observed therapy performed much better in terms of having patients, the proportion of patients with at least 80% of the doses that, the 80% of the doses administered. And so this is the intention to treat, and then this is the restricted sample where there were patients that were that had challenges just initiating the program, and so they restricted to just people who had at least been enrolled in the program, I think, for 2 weeks. And again, you see across the board, the blue bar is video directly observed therapy, the red is directly observed therapy, and you can see that over time, you can see across time that adherence remained high for those in the video directly observed therapy compared to those that were in the directly observed therapy trial or arm. But there are challenges and potential barriers to integration. One is political will, which I already talked about. And I think this really speaks to the need on economic evaluations, predominantly cost-effectiveness analyses and cost utility analyses that can show how integration really is really important, and they can show the value for money of these interventions. As I mentioned before, also changing the existing healthcare system, it will require coordination of clinical staff, patients that might be different than what a physician is normally treating. So it will require this type of coordination and from various specialties. Stigma and discrimination also remains that we've talked about a lot throughout the conference, and increasing. So there have been attempts to reduce some of the stigma associated with HIV, such as increasing knowledge within the community, the U=U campaign that's been done in several countries. And then I think the public should also be aware of the societal benefits of methadone. We know about all the health benefits, but there are also important benefits in reducing criminal activity and also reincarceration. That are extremely important that people should also be aware of. And it might help actually reduce the stigma associated with methadone. And there's also a lack of funding for these critical prevention interventions. So how do you effectively transition from these donor-funded programs that they're absorbed into the national government budget? So just to end here, so the empirical findings and the modeling indicate that integration could have substantial benefits on treatment outcomes and prevention of onward transmission of these diseases in the region. I think there should be consideration of leveraging existing technologies, such as using telemedicine smartphones. That there's a strong. What's interesting about these interventions is that the platforms and all the bugs have already been figured out. So it's now a question, going back to what Professor Baral was talking about implementation. How do you properly adapt these interventions to this setting? Because the infrastructure already exists to support these interventions. That they could help facilitate integration and successfully treat patients with comorbidities and also retain them in care as well. But there are numerous challenges towards integration that will require substantial changes at the structural, community, and individual level. So I just want to acknowledge, of course, the AIDS Foundation East West for coming here, for the invitation to present here. I also want to thank my mentors, Professor Chris Beyer and Professor Natasha Martin, and also some of our funding agencies, the UCSD Center for AIDS Research, the Elton Johns AIDS Foundation, and the National Institutes of Health, and specifically the National Institute on Drug Abuse and the Fogarty International Center. So, thank you.
So thank you very much, Javier, for a great presentation. I think we should first give the floor the opportunity to ask questions.
Спасибо вам большое за интересный доклад. Вопрос короткий и на понимание. Когда вы говорили о моделировании математическом и исследовании, проведенном в Омске и в Екатеринбурге, и вы брали 3 фактора – метадон, АРТ, но, к сожалению, в нашей стране метадоновая терапия не применяется. Ну, почему тогда вы один из факторов, влияющих на создание математической модели, брали тот, который не применяется в Екатеринбурге? Спасибо.
Thank you. So the model is looking at a hypothetical scenario. Of course, yeah, methadone, as we know, is not allowed in. Yeah. So the idea was using the best evidence that has been obtained. That is actually, we used it's called a parameter, a variable in our model. We knowing what the effect of methadone has in all over the world, global settings, the effect of methadone. We used it in our model on how it would prevent HIV and what kind of impact. It's a hypothetical scenario. Obviously, it might not be the case in Russia how it works. We know methadone doesn't work the same in different settings, but using the best evidence, what could be the potential impact if it were to be scaled up at this level? If it's scaled up very poorly, then you would get obviously very little impact. If it's scaled up to 50%, and there's a good job in retention. Retention is important, not to use it as for detoxification purposes, but for maintenance purposes. To actually have them long-term in care, then you could potentially see that impact. And there's a lot of uncertainty. We don't really know we have an idea where the estimate is, a best guess. That's what the modeling is supposed to show. And to provide a best guess of what we think could be the impact of methadone.
So if I may add, in that sense, modeling can actually be used to advocate towards politicians and other policymakers for a particular policy.
Absolutely. And that's why I was saying modeling is often combined with economic evaluations. We know that methadone is actually very cheap. To actually manufacture it and to deliver it is actually very cheap. And if we can show that on the prevention side, you can prevent so many cases by that, it's much cheaper than putting a bunch of people on treatment. And although it was kind of hidden in the model, but one scenario was just scaling up ART. And there was much less impact on preventing new cases of new HIV cases with just scaling up ART. The most impact was seen with harm reduction. So it was on the preventative side, not on the treatment side for this population.
Other questions? Yes, please.
Thank you very much for excellent presentation. I'm interested in video-controlled therapy for TB. Thank you very much for mentioning it. I'm especially interested in, do you know any publications about using it for integrated care, specifically for HIV treatment? Because we know we already in Kazakhstan, I think for several years we have been using video observed therapy for control of TB. However, a couple of years ago, we considered applying the same approach to HIV treatment, and we are faced with a lack of interest from HIV people because directly observed therapy is not required in HIV treatment world. So, what do you think about this approach and whether it has a future for integrated care? Thank you.
No, it's an important question. The example with TB is it's very clear because it might be 6 months or 9 months of treatment, and but with ART they would presumably have to take it much longer than that. So I haven't seen any specific papers. At least one of my colleagues was involved in that study, so I was aware of the application to TB. And obviously there could be a potential application with hepatitis C treatment. But with ART, I think it would be more, I could see a potential benefit in potentially rural populations, populations that might have a lot of difficulty coming in and getting tested, or getting, it'd be a much easier way maybe to monitor those groups that have difficulty accessing it. But and then maybe coming in for their regularly scheduled visits for their viral loads. But I haven't seen any specific studies on video directly observed therapy for ART. Maybe because the expectation is that they take it for such a long period that maybe it's eventually, it might be a good way to kind of maybe for a short period to stabilize, to make sure that patient's taking it regularly. And then once they've kind of managed that, maybe you don't have to do it necessarily every day. But this is more important for, I think, for tuberculosis.
Большое спасибо за презентацию. У меня просто еще дополнение, комментарий один. Интегрированный подход используется в Центральной Азии с 2014 года, ICAP поддерживает. И вот у нас основные выводы были, что эффективность подхода, помимо того, что очень близко связано с самим качеством программы, поддерживающей метадоном, еще связано с той схемой антиретровирусной терапии, которую получают пациенты. И что абсолютно важно перевод пациентов на однократные комбинированные препараты, которые могут приниматься действительно в пункте выдачи заместительной терапии, а не дополнительно. То есть если пациент получает препараты 2 раза в день, то приверженность во всех 3 странах была ниже, независимо от напоминаний и поддержки по приверженности. И единственным изменением, которое привело к вирусной супрессии, была смена схемы особенно на долтагравир содержащие препараты. Вопросы? У нас есть время еще для одного вопроса, комментария, дополнения. Если нет, тогда большое спасибо за замечательную презентацию. Действительно, это интегрированный подход и дифференцированный подход. Это то, куда все должны стремиться. И я передаю слово, тогда мы передаем слово для Михаилу Казачкину и Кейт для дальнейшей сессии. Спасибо.